All right, hello everyone. We are at 2 p.m. on the East Coast. So I want to go ahead and get us started and get us kicked off. I want to welcome you all to our Coding and Documentation Series Part 2 webinar series that we're having in partnership with Arch Pro Coding. My name is Philip Stringfield, and I serve as the Specialist of Health Center Operations Training here at NAC. I want to thank you all for joining us. And as we get started, I just want to remind you all of the NAC mission. Founded in 1971 to promote efficient, high-quality, comprehensive health care that is accessible, culturally and linguistically competent, community-directed, and patient-centered for all. And of course, that cannot be done without the work of you all at your health centers day in, day out, so we want to thank you. In addition, I want to just kick off with some upcoming events for you all. Just wanted to keep you all up to date. The Policy and Issues Forum is now going to be virtual. I know if you were with us last year, we ended up having to cancel that in-person training due to the COVID-19 pandemic, but we are going to be back this year with a virtual offering. So if you are interested, definitely make sure to take a visit to nac.org. You'll see the banner with the Policy and Issues Forum information where you can find out more about the schedule and how you can go ahead and get registered. In addition, we also have the upcoming Practical Art of Health Center Operations training. Another training that was typically in person, but is going to be virtual this year. So definitely if you have operations folks or operations folks you may know of that's looking to get some new strategies and techniques, of course, this is all going to be related to COVID-19 and how we can really just combat and respond effectively. And as you see, Brandon has went ahead and put a couple of links in the chat that will direct you there when you have a moment in time. And lastly, just want to remind you all that our COVID-19 resources are listed at nac.org/coronavirus. And as you see, we have a list of resources that we host there on that website, in addition to all the archived webinars that we've done in history throughout COVID-19 will be posted to this website as well. And you also have the opportunity to join an online Nautopod community that has been growing throughout the pandemic. And if you're interested in joining, feel free to email Susan Hansen, and her email is listed at the bottom, shansen@nac.org. And to help us get through today's presentation, as you see, there is already about 160 participants on the call, and we are expecting more. So please make sure that you have your questions in the Q&A section. As you'll see, that's to the right of your screen. We want to make sure that we're keeping these questions directed to the Q&A, so that way we're not getting lost in the fog and all of the chat in the chat box. So if you can tie all of your questions, make sure they're specific to the Q&A box. We'll make sure to get those questions answered at a reasonable time throughout today's presentation. All right, so here we have it. So we'll be talking about treating substance and opioid use disorders via medication-assisted treatment in community health. And today we'll be looking at how we can identify where the rules and regulations around documentation, coding, and CMS billing for MAT services, and how commercial insurers may want the services reported differently than on a Medicare claim. We'll also be looking at how to understand how to correctly report services as non-face-to-face, behavioral health integration, and the psychiatric collaborative care model. And lastly, we'll be identifying the full range of options available for ICD-10 CM codes and how the DSMB clinical measures or manual can be used by clinical providers with different terminology than the ICD-10 CM requires. But before we get started and I hand things over to Gary, I just wanted to remind you all, if you have received or if you have not received an email from me, this is probably due to your organization having whitelisted our organization email. So I've been sending out reminders, I've been sending out calendar invitations, and I've already sent out the copy of today's slides. You would have received that from keithspringfield@nac.org. So if you haven't, just make sure to contact your IT over in your organization to see if you can allow emails from our organization. In addition, I did want to just go ahead and put a note that the recording for last week's session has hit the clearinghouse, and we'll make sure to put a link in the chat as well where you can get that recording, and also you can get the CEU, but just please make sure you are recording it correctly and viewing the entire presentation before completing the CEU certificate. So with that, I'm going to go ahead and hand things over to Gary to get us started today.
All right.
And you got the ball.
And we have that going there. All right. Well, I wanted to also take the chance to thank you guys for taking time from your busy days to carry on the discussion from what we talked about last week. Several of you had some email questions that came through afterwards, and I think there are about 30-something questions, so I'm not able to answer those individually. But as I give you my contact information today, if a question that you had from last week's session was not answered, please feel free to contact me directly. That is kind of what I do. Two issues really kind of rose to the top of a lot of questions last week. And one of those was a bit of surprising news that I shared with you before we go into today's topic to finish up last week's topic, that there are many services that you're not used to getting paid for in an FQHC, let alone getting paid for them through distant site telehealth. I gave an example of a 99211. I gave examples of group psychotherapy, things that will tie into or may tie into today's discussion. But I did want to be able to give you the source, and straight from Medicare here, if you go to cms.gov, you click on Medicare. If you then click on federally qualified health centers, there's a little reminder here about new payment for telehealth services. And here is the sentence I wanted you to see that confirms that, yes, you may report even a 99211 or group therapy if it's on Medicare's distant site telehealth list for the traditional fee-for-service folks under the fee-for-service schedule. So there it is from Medicare. I wanted to kind of, document that and give you that access to the link. You'll notice on the screen now, if you just went and Googled implementing CPT E&M revisions, you would be able to then go have a summary from the AMA based on everything we talked about last week. So I want to go ahead and jump into today's presentation. One of the things you may have seen there on the screen a moment ago is that there were about 18 different links that I'm going to be providing you, maybe more, for some hyperlinks that are in today's presentation. I've been lucky enough through ARC's Pro Coding for the past several months to participate in HRSA's RCORP program, the Rural, let me make sure I get this right, the Rural Communities Opioid Response Program implementation. And we've been through a collaborative agreement with an organization that's tied in with the Rural Communities Opioid Response Program. We're actually out there providing training to grantees who are receiving funds through RCORP. And I look forward to the chance to share today's 1.5 hour with you. And we're actually going to be doing a 4-hour class today. So please, if you have not already, grab my email address. If you have the slides, you can reach me at Gary at ARC's Pro Coding. Keep in mind that ARCH stands for the Association for Rural and Community Health Professional Coding. We focus only on rural health clinics and FQHCs, along with critical access hospitals, those of you providing care in underserved areas that are often under-reimbursed by carriers, and that ties in to some of these services we'll be mentioning today. Our target audience today is made up of hopefully clinical providers who are responsible for documenting 100% of what was done in the medical record. And granted, we know the coders and the billers are the ones submitting the claims, but it is, in my opinion, facility leadership's job to really bridge, whoops, the timing went there, to really bridge a gap of knowledge in between the clinical providers who clearly have a clinical focus, but do have a responsibility from the revenue cycle to make sure the notes are documented, here's the key, just like last week, according to the guidelines printed in CPTs, ICD-10s, etc. And so hold on to your chairs, because everything you provide related to medication-assisted treatment and substance and opioid use may not be reimbursed. There may be services that need to end up on your cost report, but just because you may not be receiving direct reimbursement from them through your PPS rate or through case management services, et cetera, they still have to be documented carefully in the medical record. And so we hope that Team-based training is a part of your everyday revenue cycle training. But one quick little item here is for those of you that are looking for the potential to start one of these programs in your organization, I'll tell you right now that you may, pending the specific details in your state, make available for your clinical providers more loan repayment programs that they can utilize to get anywhere from $75,000 up to $100,000, I believe, in loan repayment by participating in the Health Professional Service Corps. I think I might have just flipped a couple letters there, but you may only have eligibility for one of the three programs in your state currently. But if you implement an approved medication-assisted treatment program, your providers, your MDs, DOs, PAs, and MPs might be eligible for all three. So anytime you have a scenario when you can deliver new and needed services to your patients, not only learn about revenue opportunities, but we can get our providers to come to our urban and rural health professional shortage areas, to me, is absolutely positive. So the general layout of the slides here, we'll start with talking just about the idea that medication-assisted treatment often requires an integration between our medical providers and our behavioral and or mental health providers. So we'll talk about a quick outline about initiating staffing and just being ready to either develop your program or be able to measure your existing program's performance based on some standards put out there by some organizations. But the goal today is not just to talk about how to document, code, and bill for face-to-face services. We'll also talk about how you may not have behavioral health located in your facility. You may be making external referrals, but you may provide some non-face-to-face services that are reimbursable in between visits. And so that's where we'll talk about at the very end the behavioral health integration and the concept of what's called the psychiatric collaborative care model. So as we move from integrating and managing primary care and behavioral health services, we'll provide an overall outline of documentation and coding. We're going to introduce you possibly to some codes that are going to appear in the HCPCS Level 2 code book that begin with the letter H that might identify codes you need to use for Medicaid, which could differ from the way you report the services to Medicare, which could differ from the way you report the services to commercial insurance. And so we'll outline some of these options for you, and I'll even give you a sneak peek into what I believe may become, several years from now, a unified method of reporting substance and opioid use disorders using medication-assisted treatment as the foundation there. Clearly, we are obligated to not just submit the CPT and the HCPCS codes, but our documentation guidelines for diagnosis codes are going to override some issues related to CPT coding, especially when, as Philip mentioned in his introductory slide, and as it was laid out on the course objectives, that there's a difference in how the DSM-5, the Diagnostic Statistical Manual, version 5, that outlines how clinical professionals in mental and behavioral health actually how they determine the diagnosis. You know, they're using a multi-axial approach, and the DSM-5 identifies a clinical approach to determining mental and behavioral health diagnoses. But the terms used as an output from the DSM, the clinician says, I've identified that this patient has an, quote, opioid use disorder. Well, there's not a generalized ICD-10 code that matches up really well with that, because the ICD-10, as we see, is going to require that we at least get down to a little bit more granular level of opioid use versus opioid abuse versus opioid dependence. And so making sure all of our clinical professionals realize that if we just use, because I'm busy, I've got patients coming in, and I click on opioid use, opioid or substance use in and of itself depending upon the carrier you're reporting to, may not reimburse use. They may only reimburse or reimburse at a higher frequency if the patient has opioid or substance abuse and or dependence. But then we get into details in the ICD-10 that don't appear in the clinical module. So managers, it's going to be your responsibility to help bridge their clinical definition with the coding and billing definitions of diagnosis codes. And so at that point, we will have already introduced it in the first chapter, but we'll review the major category or major steps, I should say, of medication-assisted treatment. In its short form is providing medications via pills and or injections, etc., that either block the patient's receptors for an opioid. Basically, it won't work, or it won't have the same, it'll block the reaction, or it's going to limit and deaden, if you will, the impact that those medications have, so that over time, once you screen the patient, determine they need to get medication-assisted treatment, you give them the first couple doses. That's the induction. Then over time, the first couple weeks, you're going to then stabilize the patient. You're going to maybe draw labs when they come in. You're going to maybe track their utilization of the substances if they're taking them at home, or tracking your visits in your office if you're doing injections. And then over time, you're going to maintain those patient visits and then begin to wean them off of the substitute medications: buprenorphine, Suboxone, naltrexone, methadone, etc. And then we'll finish here with those non-face-to-face services. I know I did, and I mentioned in the E&M session last week that we'd talk about transitional care management, but I decided to go ahead and bring it into this session. But we talked virtual communication services last week. We'll skip that today, but we'll finish up with these, quote, non-face-to-face or blended non-face-to-face and face-to-face reimbursement that may allow you to capture revenue from things you're doing in between visits. So keep in mind that our primary focus here is on the documentation, the coding, and the billing here. But there's going to be a need for obviously additional research and programmatic advice and staffing advice for creating a business model that truly integrates medical care and behavioral health. I'm not a clinician, but it seems that most of, if not all of the evidence out there says that a medical provider who's going to be providing those substitute medications under medication-assisted treatment, that the patient may benefit and may even be required to be referred to or given mental or behavioral health care to deal with the potential underlying behavioral issues that contribute to or maybe a causal factor in addiction. And so the business model is vital. We're not going to get too deep into that, but I am going to identify many, many resources for you to be able to utilize all the way from the screening phase, which, by the way, may take place during your initial preventive physical exams. It might even take place during your annual wellness visits. And those are Medicare terms, but Medicaid and others tend to follow the lead there. So before we're beginning, you have to ask yourself or ask your colleagues if you're truly ready or fully prepared and enabled to get the job done. First of all, do you have your current 2021 manuals? Any answers to questions may come from those manuals. We talk in every one of our sessions and those that we do for NAC that you need to go to the Medicare Policy and Benefits Manuals, Chapter 9 and 13. I'm going to give you a peek at those today, but I will acknowledge and ask you to acknowledge that on the objectives, we did have to point out that any Medicaid questions that you may have, not only may they differ from the other states, because we had 500 and something people registered for this class, but they may even vary within your state. But I will provide a recent potential update and some recent positive changes that have occurred even in the last 2 weeks related to different waivers and different administrative things you need to get done. But the level of detail you need to fully understand Medicaid reimbursement either has to come in the participation contract with that specific carrier, or you have to see if your state has issued overriding guidance that each of your Medicaid carriers must follow. And by the way, excuse me, don't be surprised when some of the Medicaid guidance and rules and codes differs from the way traditional insurance and or Medicare might want them reported. So we'll capture that. And so the focus here is that Medicare billing is going to vary from Medicaid, whether it's FDA requirements, scope of licensure requirements, and who are your, quote, authorized providers. Now, again, the medication-assisted treatment portion of dealing with opioid use disorders is going to be done by, primarily, almost exclusively done by a medical provider. But whether they have behavioral health on-site or you're referring out, you got to be careful who the authorized providers are. Medicaid might pay for a limited version of a clinical social worker. An LCSW may be defined differently than a licensed professional counselor. You may have a clinical social worker that earned that certification and designation in your state, but they haven't performed the required Medicare 2,000 hours of clinical time before billing, et cetera. So be cautious with authorized providers, and they may even differ based on the insurance plan you're dealing with. Those issues are going to have to be dealt with on a state-by-state basis. If you have an automated prescription system, finding the behavioral health manual from your state Medicaid organizations, and really working with your state and national, of course, primary care associations or community health associations who may have really good feedback and good workings with the Medicaid program. Michigan, for example, I've worked with their primary care association several times, and they bring in the heads of Medicaid to talk coding and billing of various things. So we look forward to and hope that you have access to that detailed information. Now, here's some brand new information that came about less than a month ago. And please notice in your presentation that I will do my best to indicate when there's a hyperlink tucked into your PDF. And so although I may not have the website up there that you can copy and paste, this entire block here is a hyperlink. And if you'll allow me for a brief moment, I want to show you, well, I'll get to this document in a moment, that when you see words like this coming a couple weeks ago, that state mandatory Medicaid state plan coverage of medication-assisted treatment, that's the stuff that makes me jump out of my chair. And so the basic gist of this document that was listed as being delivered to state health officials, and I'll even show you the document here at the end, notice that the statements to increase access to medication-assisted treatment for opioid use disorders requires states to provide Medicaid coverage of the drugs. There are really no biological products available, but they have to use that term, and related counseling services and behavioral health hopefully will counter some of the negative reimbursement issues you're dealing with Medicaid. So I wanted to alert you to this document, urge you to go get the full letter. But what I've done and my little picture down here is covering up my slide numbers. There we go. On slide 9 is I wanted to take little excerpts and just draw your attention to a couple areas that caught my eye. This is going to be one of those links that I have out there that'll help you out. Now notice that this has the new required benefit will be in effect for the period beginning October 1st and ending September 30th of 2025. Folks, if you have significant denials from Medicaid programs listing services as not medically necessary or not covered, and you are still within the timely filing limits, which you clearly are, or assuredly are, only going back to October, you may find an opportunity to get your billing service or your internal billing staff to go appeal some of those using this letter as a document to help overturn denials for Suboxone, buprenorphine, naltrexone, etc., and or the counseling services that are assuredly clinically appropriate to not only use the medication-assisted treatment by the primary care provider, to hopefully eliminate the addiction and dependence, but can be utilized to help maintain behavioral health and positive processes that your mental health professionals are engaging the patient in to restrict, eliminate, or at least reduce the chance for resuming that potential addiction. Page 2 says that the FDA lists methadone, buprenorphine, and naltrexone. Some of you that deal with Suboxone, which is a different version of buprenorphine, if you will, they have a nice little breakdown on page 2 for these. Little side note, methadone is still an approved medication, if you will, for opioid use disorders, but traditional FQHCs, those of you in community health centers, you're likely not doing methadone unless you've opened a separate methadone clinic under what's called an opioid treatment program, a CMS-approved OTP, opioid treatment program. So methadone is on that list, but unless you're in one of those programs, the two primary vehicles are buprenorphine and or naltrexone. So the details continue for each of those drugs commonly used in medication-assisted treatment. And this is what I kind of didn't do a good job of saying earlier, that buprenorphine/Suboxone is a partial agonist, which weakly activates the opioid receptor. In other words, it makes the quote-unquote bad medications, bad drugs, whether it's prescription or illicit drugs and so forth, my non-clinical way of using it, it makes it not work as well. And then you start to wean the patient off of the bad meds or the medications that cause the issues, and then slowly bring them down off buprenorphine. And there's a lot of evidence out there that although you are required to get an additional set of training in order to offer buprenorphine, there's some changes and updates I'm going to give you that literally came as recently as this morning on that issue. Whereas naltrexone is not addictive, it's an antagonist, and it literally should, from my non-clinical way, block the ability of the opioid to even work. So that nothing's going to happen. It's going to block that program. Some have issues with buprenorphine and that the patients may, quote, become addicted there, but I'll leave that to the clinical folks. And then on page 4 of this, I think it's about a 7-page document, it's a breakdown of the required MAT benefit to include, and this is a very, very positive, peer support. So peer support specialists. These are folks, let me get rid of this, these are folks who have already, let me kind of pull this document up here, these are folks that have gone through substance and or opioid use disorders themselves. In some states, the training that it takes to become a peer support specialist is more formalized, maybe even a certification/credential, in which case you'll likely find it a bit easier to get reimbursed for their work, whereas peer support services, let me make the screen a little bit larger here, although we want it to become more reimbursable, they're not an authorized and licensed provider. But what I loved about this statement here is that CMS has previously issued guidance that addresses peer support services. These are folks that you may alternately call a recovery coach, who's going to be a team member in between the medical and the behavioral health work. The problem is when you go look at the footnote here, number 17, you'll notice that that document is over 10 years old. So we're still waiting on more detail there. Let me get back to my slides. And so the continued items that are there is also on page 16. So actually this is the longer document, excuse me, it's closer to 20 pages. But they also talk about the appropriateness of telemedicine to be used as a tool to expand buprenorphine access for opioid treatments, especially in rural areas. Well, folks, that ties back to our discussion last week on how to monitor Medicare's periodic release of the telehealth covered services list. And again, as I showed on that CMS page at the very beginning, even though we in the past have not been able to provide all the same services as those that are in a regular practice during the public health emergency, we have a much more expanded list. So hopefully everybody here is as excited as these folks here. Let's go over some overarching issues related to integrating primary care and behavioral health. And I've been lucky enough to work with, like I said, at the federal level with HRSA to provide documentation, coding, and billing training for RCORP grantees, the Rural Communities Opioid Response Program implementation. But my dear friend and colleague up in Michigan, Jill Osterly, works with the Northern Michigan Opioid Response Consortium, and I just really liked one thing they had on their website. And you will also see, if you haven't already begun medication-assisted treatment and you're looking to develop or you're in the process of doing it, one of the first things you'll read about and will see is that stigma reduction is key. And folks, that applies internally in your office, let alone with the need to create an environment that allows these patients to be seen as having an addiction, which is a chronic reoccurring brain disease. I need to get my my highlighter back on here briefly. And that the reoccurring brain disease, it's not an issue of weakness or social stigma. It's a reoccurring brain disease is what addiction is, and it requires mental health first aid training. And the impact the positive impact that treating this addiction is going to have on their other physical problems will probably be rather significant. So, you know, I carry around a lot of different materials. You see me hold these books up all the time. But one of the things I got from Miss Sherry Poe Bernard's book called Risk Adjustment, Documentation, and Coding, is that changes in the patient's brain makes it difficult to resist the urge or to abuse the drug, or having resisted it, make it easy to relapse. And that applies whether it's tobacco, alcohol, and or an opioid. So I'll be careful when I'm talking about SUD, substance use disorder, leaning towards tobacco, alcohol, things like that, with opioids or opioid use disorders. And so we'll talk about screening, induction, stabilization, and maintenance coding and billing for both opioid use, which is more on the medication-assisted treatment side of things, varying from tobacco and alcohol. And that susceptibility is not just based on their behavior. It's based on genetics, the environment, and when in their development they started using that substance. And I loved this example, and I adjusted it slightly from Miss Bernard, who I was lucky enough to meet for the first time back in the 90s. But the ICD-10 codes may be the same for patients who are injecting illicit or illegal opioids, or if they're diagnosed with an opioid because they had back pain, they had back surgery, they were correctly prescribed a prescription, and they have unfortunately developed a dependence or abuse there. Or it's a patient that's receiving a prescribed dose of naloxone for overdose reversal. The code may be the same. So stigma reduction is key. I've had people off the record say, I was told we're not going to provide these services for those patients before, and it kind of shocked me there. So I just thought I'd bring that up, that stigma reduction is a key, and it's going to be part of the training and ongoing training that you have when you initiate and continue medication-assisted treatment services. So the provision of the medications, as we mentioned up top there. Remember, please, I don't just read from my slides, but I hope you are comfortable using these slides to train your folks. And so sometimes I'll just give you 3 or 4 slides and tell you what's there. Sometimes it's going to remind me whether or not I've talked about it. And so this is the reminder that your medication-assisted treatment is done by medical providers in conjunction with internal or external behavioral health services. But wait a minute. Your state may require, let alone HIPAA may highly recommend, that if you happen to have a patient receiving medical services for hypertension, diabetes, or opioid use disorders, but when you have them receiving medical or behavioral or mental health services, some states are going to highly recommend that you keep those notes completely separate from each other, maybe even in a different medical record. Now, granted, if you have an electronic health record, there's a different issue there, but you should not allow the same access to a patient's mental health record to internal and external folks, and even the patient in the same way that you would give the patient access to their psychiatric health records and other providers. They need to be treated differently, and whether it's a separate chart note, a separate EHR, or a set of policies that restrict access and requires a more rigorous process of releasing that information than medical records would, please do keep this in mind. Now, notice this word trained. Trained primary care providers. Well, you know, buprenorphine happens to be, if I've got my information right, the only medication out there that I'm aware of for providers that already have a DEA certificate that requires an additional training program to get a waiver to allow you to provide buprenorphine. Now, there are issues, I should say, recent updates that I'll be sharing with you soon, but there is the need to obtain what you might have heard called a Data 2000 waiver to get an X-DEA number, Drug Enforcement Administration there. So when you see that word train, that can generate a discussion there. And I can't recall if it's in the slides or not, but for buprenorphine to get that Data 2000 waiver, it's like an 8-hour training course for MDs and DOs to get a certificate to allow them to prescribe buprenorphine if your state hasn't already allowed it, okay? But your PAs and your MPs will have to go through a 24-hour training program in order to provide buprenorphine, again, unless your state has already issued guidance allowing it or requiring a different methodology. But I do reference here at the very bottom of slide 13, NAC's guide on charge capture that we're going to reference later in class. Now that I think about it, it's actually only a slide or two, but it is a wonderful document created by NAC, by Ms. Shelley Sulzberger, and it was created or released in about November of 2018. There have not been significant coding changes, so it's pretty much up to date, but there's some wonderful programmatic information from NAC that I've utilized in this class, and I want to give credit where credit is due. And that one of the things they think we should be doing is scrubbing our charts 2 to 3 days in advance of most, if not all, patients' visits to determine if they have already been screened or may need to be screened for alcohol or substance use issues. And so some of those screening tools could be part of my annual wellness visit and may not be billed separately. Whereas maybe if I did a ESPER tool or use the CAGE aid tool, the screening behavioral intervention. And so be aware that identifying potentially high-risk patients is one thing, but making it a routine part of your initial preventive physical exams or preventive services may give you the opportunity to generate the opportunity for patients to get on the path of healing there. And so the basic phases of MAT are screening for and or diagnosing. Now remember, your clinical providers refer to it as opioid use disorders, but the ICD-10 is going to require more detail. But then we have to choose the medication. We then initiate, as I mentioned earlier, the patient. We give them their first dose or dosages. We then stabilize them over time. And then we maintain that over time and begin to wean them off those medications. Well, folks, it's no big secret here. Those are primarily going to be done via evaluation and management services. Now, the screening and diagnosis, they have some G codes and they have some CPT codes. So my handwriting on the screen might make it actually worse there, but we'll get that to you here shortly. So just to confirm the definitions of induction and maintenance, take a moment here on slide 14 while I grab a quick sip to understand the differences in induction, stabilization, and maintenance. All right. So again, you'll see a slide sometimes that will outline what we've already talked about, but I want to make sure you have it in writing there. Here is that guide. Now notice again, this is a hyperlink. Let's see if I can get my mouse here. This is a hyperlink. The entire little picture there is, and establishing a collaborative model that allows not just internal screening, but establishes a collaborative model between your facility and the emergency room for patients that might come in intoxicated or in crisis state under the influence of opioids. Who do they know is in the community providing this type of care? And so without, clicking on this link at the moment, the guide for documentation and charge capture that Nat created has a lot of things about screening recommendations and scrubbing charts ahead of time, creating these collaborative internal and external referral models. I just really think it's a wonderful manual. And so the management of those various types of communication expand beyond just moving the patient physically between the emergency room and then maybe to your clinic and then maybe to behavioral health for parallel behavioral health treatment while the medication-assisted treatment is happening, making sure during those visits you're testing for labs, you're performing what are called qualitative or quantitative lab screening. Qualitative literally determines whether a substance is in the patient's body or not. It's a yes or no. You've been on medication-assisted treatment for 3 weeks. You told me you have not taken blank medications. The lab shows something different. Whereas quantitative testing can help determine the levels, like blood alcohol screening would be a quantitative model because it's determining the amount here. But it's the care management and the coordination with our last issue that I'll talk about today that I want to bring up again when you're establishing those collaborative models, because you may have behavioral health providers across town doing the behavioral therapy while you're doing medication-assisted treatment, but there's communications between you and them over the course of the month about that patient's care, and how you capture that could determine if you're getting paid for the equivalent of chronic care management on the behavioral health side of things via the behavioral health integration concept, new to the CPT 2 or 3 years ago, and the psychiatric collaborative care model. That's the COCM. So developing the internal screenings and external screenings and so forth is really kind of what we're talking about there on slide 15. And if you'll allow me a brief moment, I want to show you how great, let's see if I can get this out of the way, how great that document is. So here is it, 26-page guide, documentation and charge capture, created in conjunction with providers, clinical support systems, and NAC, and giving the authors just absolutely appropriate credit where credit's due. Please, when you get the chance, review this document. There's information for managers in terms of, creating the program, for those on the EHR and the data side of things or the public health reporting requirements, workflows about who needs to be trained on providing various upstream and downstream deliveries to develop effective workflows is there, all the way to care management. But I'm going to scroll back here to appendices D, E, and F, which I'll reference a bit later, where you'll see, let me get back to D there, where this guide does a great job, just so you know that you have another document, of breaking down traditional induction visits. This is assuming you've already done the screening, you've determined an accurate and applicable diagnosis. Now, granted, as we said last week, 99201 was deleted in 2021. So again, just read it with a 2021 filter on, but it's providing options not only from the CPT, but your FQHC specific code. Since this was created in conjunction with NAC, it does have a good FQHC focus, whether prolonged visits are needed, how the follow-up visits, let me see if I can make this a little larger, known as maintenance visits, will be billed based on those key components, which in 2021 is time and or medical decision making. We did a whole visit on that last week. And then confirmation of behavioral health, doing a psychiatric diagnostic evaluative interview, either with or without medication or medical services, the therapy services. Each of these codes in the presentation I've given you in PowerPoint, I'm going to provide you with additional links to the documentation requirements for the psychiatric diagnostic evaluative interview, the psychotherapy codes, and even other codes referred to as interactive complexity. And so whether it's group therapy or psychotherapy, there you go. And then additional information in here for screening services. For the screening services, or brief intervention services, both CPT codes, typically commercial insurance, and or for Medicare. And so I'm going to minimize this at the moment, but I wanted to make sure that you have access to a document that I used to build this presentation. But I wanted to also reference you to what's called MedLearn Matters. So this comes from this comes from CMS. All right. So MedLearn Matters, released a couple years ago, is something that confirms the appropriateness of using, or look at this, they would like to emphasize that the review of opioid use is a routine component of your initial preventive physical exam or annual wellness visit. If they're not a Medicare patient, then what about those EPSDT services that would include a teenager that maybe has a problem or an issue related to substance use or opioid use? And so I'm going to give you a hyperlink to this document so you have access to it. Here's my reference on slide 17 that I, in relation to the NAC developed resource there. And slide 18 is a place, without me going and showing you the document, that you can utilize with practitioners, managers, or revenue cycle staff, because you may have your third grade teacher, bless her soul, she's 81 years old, she's coming into your office. You might feel weird asking about substance and opioid use. But the providers who are aware that a reasonable response would be, well, your insurance company, Medicare, has recommended that this become a routine part of our care, et cetera, et cetera. So utilize these documents. You'll notice the references to those appendices, E, F, and G in that NAC document, and you've got two rock-solid resources there to help you out. And as we're kind of finishing this more on the institutional or internal creation of a business model and the coordination of referrals on how to keep the medication-assisted treatment and or behavioral health working in parallel towards common and shared goals. This is what you can use that was created by the National Council for Behavioral Health, that you can use as you're creating or looking to create or looking to evaluate the performance from a programmatic level of your medication-assisted treatment issues. And so I pulled this page, even though this is a longer document, from the hyperlink down here, but the idea of researching Medicaids to determine what the rules are for sublingual buprenorphine. Okay, so going in under the tongue there, or injectable naltrexone. And sometimes they may have shots that last longer, like once a week, as opposed to more often. What are the out-of-pocket costs for meds? Are clinicians eligible to receive reimbursement? And so you'll notice you can go in and kind of check and get an idea about how you're doing, or whether or not there are activities or actions that need to be taken by everybody to build up a good program. So if you're going to look at the major issues related to staff training for medication-assisted treatment, you got to know the updates that we talked about last week for evaluation and management. You're going to need to be aware of the documentation requirements for behavioral health and psychotherapy. And for example, in your CPT, and I know it's going to be pretty tough to see here, but even that one little add-on code I mentioned a moment ago called interactive complexity, when you have to use additional techniques as a mental health practitioner to overcome barriers to communication. You maybe have to use toys, dolls, physical aids, translators. Well, folks, there's over a page and a half of information printed in the CPT that describe how you would use the add-on code for interactive complexity. There's 3 paragraphs of what you need to document when you're doing a 90791 or 90792 for the psychiatric diagnostic evaluative interview. So it's not just making sure the codes are on your super bill. It's making sure your providers have the full definition of the codes on their encounter form or super bill, backed up by knowledge of the documentation rules that are only printed in the CPT. On top of that, there are, geez, I didn't count them, but probably over 36 codes in the HCPCS Level 2 code book, not your CPT, where the entire section is dedicated to alcohol and/or substance use disorders and are likely going to be needed by Medicaid. So training providers on the differences in coding and billing, that we need to code everybody the same, but codes might change on the bill depending upon if we're getting paid our PPS encounter rate, which is on that CMS 837 form, or you might call it the UD form. But the codes might look different if I'm billing commercial insurance, getting paid fee for service. You've got to be aware and remind our providers that coding and billing are two different things. Understanding the variations in which carriers are going to pay us for group therapy. Again, Medicare does not pay an FQHC for group therapy, but during the public health emergency, they will if it's done via an approved telehealth module. And so understanding those differences not only during the public health emergency, but as we move forward from plan to plan is extremely important. And what we're going to jump into here shortly again is noticing the required level of detail that needs to be included not only in the ICD-10 codes you report, because I can report or pick any diagnosis code by clicking on it, but that doesn't necessarily mean that that matches what the documentation was in the record. And so we'll have to review and understand that. And if we have a patient that comes in with associated conditions that might be related to their addiction issues, such as HIV, endocarditis, viral hepatitis, maybe they have a septal damage in their nose from cocaine, well, knowing what order the diagnosis codes go in is going to be extremely important. For example, the order of the diagnosis codes that you report on the old UB form doesn't really matter. You just list them. But the order you put them on, if you're billing an insurance company fee for service using that 1500 form, the order of the diagnoses is vital. We'll elaborate on that here shortly. So let's hit that information related to diagnostic documentation. I will say, Philip, and I should point out to everybody, please, I cannot see the chat box. I've hidden the chat box so that I can stay focused here. But Philip, if there is a question, or at least a question that you see may have popped up more than once, please do feel free to jump in, not only on these little section slides, although we'll handle the vast majority of questions at the end of the session. If there is something that needs to be pulled out, Philip, I welcome, especially at this point, for you to bring them up. Otherwise, I will just continue to roll, but please feel free to jump in if needed.
All right, will do. Thanks, Garrett.
You got it. All right, so where do I find this information? Well, it's the official guidelines for coding and reimbursement. That's what you need access to, because a provider can select a diagnosis code, again, by clicking on a pull-down menu, but making sure that we report those diagnoses in the correct order, on the correct date, and that, as we described last week, that you're not reporting every single diagnosis the patient has on every single visit unless you're actually treating them on that date. So the behavioral health provider might use PTSD or depression as their primary diagnosis, with the substance abuse or substance dependence as the secondary diagnosis. Whereas the medical provider, that's the one providing the medication-assisted treatment for an opioid use disorder or abuse or dependence, they're going to use that opioid abuse or dependence as the primary diagnosis. But if they happen to mention that the patient's also receiving medical care or mental health care for the depression or PTSD, or their status post, laminectomy because they had back surgery, then those supplemental diagnoses do need to be listed. And so the basics of diagnostic coding and understanding the notes that happen to appear next to codes, that, hey, do you have to code another diagnosis first? Or are you required to use another diagnosis code in order to report this service? these guidelines are vital. And while Section 1 in these official guidelines is only about a page and a half, Section 2 goes into more detail on what if we don't have a definitive diagnosis? When can I report the signs and symptoms? How do I capture rule-outs or questionables or probables or suspected diagnoses? When are there combination codes in that it used to be 2 or 3 different diagnoses, but now there's maybe 1 diagnosis code? So Section 1, subsection B is going to give your provider the foundation that we believe you need in order to accurately report what's going on. But what about these diagnoses that a lot of your Medicare managed care organizations want, in addition to the diagnoses for the medical or mental health disorder? What about those social determinants of health diagnosis codes? How are they used? When are they used? They came up in our discussion in the E&M session last week. I'll show you another place or two where that's going to pop up today. Well, the place you find that detailed information, as well as the primary diagnoses used for medication-assisted treatment and or substance use disorders, are found in Chapter 5 of Section 1, subsection C. And if you don't have them in your actual ICD-10 manual, I wanted to show you how quick and easy it was to pull them up. And I have to drag this little panel down here. Where we go? Here we go. You just literally Google ICD-10. Let me show you how quick I did it. I Googled ICD-10 2021 guidelines. Boom, you click on it here. The first, heading there, the first couple pages, subsections A, subsection B. They added some information on coronavirus. What all you do is go down here to Chapter 5, boom, and you have access to the mental and behavioral and neurological or neurodevelopmental disorders that you're going to need in order to correctly report the diagnosis codes for what we're doing here. So please go get access to this general information in the first 2 subsections and the more detailed information that I'm highlighting here for you on slides 25 and 26. Now, in the DSM, the Diagnostic Statistical Manual, that clinical book that mental health professionals use to get to the clinical diagnosis, they may have words in there, like mild. Okay, I need to get my highlighter back here, like mild or moderate, that will not or may not correspond to ICD-10 at all. So having the discussion with providers that how you determine your diagnosis may be different than the diagnosis that we need on the claim form to get it paid the first time, rather than coming back for extra information later. So specifically, when I show you a good list here, I want you to compare and contrast how the DSM refers to remission. So as you move through the maintenance phase to end and start, tailing off of medication-assisted treatment, we should be able to see that the patient's in early remission versus late remission. Well, some categories go deeper than the DSM does and gives more detail that's needed. And so when I spoke a couple moments ago about not knowing when we list all the diagnoses the patients have versus only those that we treated that patient for on that date, I also pulled from Ms. Bernard's wonderful second edition of her book, available at the AMA or on Amazon, or whatever there, is that idea of a septal ulcer due to cocaine use. Now, the idea that the patient is having a heart issue due to methamphetamine use, but the order of the diagnoses is vital. Not as much when you're billing Medicare or Medicaid, getting a PPS rate using that UB form, because you don't have to link procedure codes to diagnosis codes on that form, but on the 1500 form to commercial insurance and likely Medicaid, we need to be aware of it. But what about a patient that's coming in for their physical, their preventive visit, their initial preventive physical exam, or their annual wellness visit? This is vital right here. If documented drug use is not treated or noted as affecting the patient's physical, mental, or behavioral health, do not code it, the exception being for patients in pregnancy. Now, that is referred to in a couple different areas of the ICD-10 official guidelines, but Ms. Bernard gave this good example here, and I hope is important in terms of assisting you in overturning denials that may happen. For those of you that are in an accountable care organization trying to achieve shared savings based on quality reporting guidelines, I do encourage you to be aware of, and if you're not doing that, you're not in an accountable care organization, you're not doing quality reporting, the words hierarchical condition categories may not make sense. But let me just state quickly that some of the diagnoses found in HCCs 54, 55, and 56, which is basically a list of ICD-10 codes, will risk adjust that specific patient's reimbursement if you're getting paid a per member per month rate. So although the previous screen was, hey, don't report it if it doesn't affect their medical or mental health except in pregnancy, the difference may be that managed care may require you to submit a periodic or a quarterly or an annual list of every diagnosis that that patient has, not just what you treated on that date. And understanding the diagnoses related to substance and opioid use will not only give public health access to this valuable information, but may actually increase your payments for per member per month. And so some of the other codes to be aware of that might deal with quality reporting is that if the patient does come in intoxicated, that in addition to that intoxication, things like listing the blood alcohol levels, and I'm giving you a little example on 26 you can look at when you get the opportunity. We're going to keep moving on here. But this is a highlight literally out of the ICD-10. So this is a screen capture there confirming that if your provider's documentation uses use or abuse or dependence, or in these cases, what if they use more than one of those terms? In this case, you need to know the hierarchy of if both use and abuse are documented, you go to the higher level, abuse. If abuse and dependence are documented, only assign dependence. And so ensuring that each of your providers is utilizing the same definition of abuse and or dependence, maybe based on a different impression from the Diagnostic Statistical Manual, is a conversation that really needs to happen so we can ensure we're reporting diagnosis codes in a standard and consistent manner based on your documentation. So I gave you the chapter 5 talking about use abuse there. I'll show you an additional, actually I take it back. I want to thank Philip again and Brandon and Olivia for emailing y'all not only these slides, but the extra full list of all the diagnoses found that start with the letter F related to mental and behavioral health. Different words that you're going to need to see not only your provider click on to assign a diagnosis to a claim, but that needs to be supported in the medical record. So remember, assigning a diagnosis isn't the same as documenting it correctly and then reporting it. And little summaries here. The codes might vary if it's mild, moderate, or severe. And we've talked about that there. So here is the list of codes from F10 to F19 in a very short format because it wasn't Michigan, but there's a couple other states that I've worked with, South Carolina and others, in providing this care where some of their public health folks came to sit in this course. They said, I don't know anything about coding and billing, but maybe we'll pick some things up. And I started showing these slides. They went back to their reports and really saw there were only a handful. I don't remember the number. They showed me a list, but my gut says 5 or 6. They only got access in their state, and this wasn't South Carolina, but a list of a handful of diagnoses being used statewide, when in fact alcohol-related disorders have different codes than opioid-related disorders. They weren't getting other associated diagnoses that would have gone along with that opioid-related disorder. And notice under opioid-related disorders, in this particular case, there are no codes for use. So the recommendations that are given tucked into the actual ICD-10 manual that your providers maybe have never seen, no blame, But we need to be aware that mild use will be listed and coded as abuse. Or if it's moderate or severe, you code that to dependence. So your providers are using terms like mild, moderate, or severe. What they may not be aware of and what we want you to utilize when building your encounter forms and training providers on proper diagnosis coding is that there's some unique issues related to each category of diagnosis that need to be discussed carefully. Cannabis-related disorders, the same tip there above. There's no use, there's only abuse or dependence. All right, sedative, hypnotics, or disorders related to anxiety also don't have use options, but notice the sedative or hypnotic or anxiolytic disorders might include requirements for you to indicate whether there's current intoxication and or withdrawal issues, unlike the previous three sections. And so I'm just listing them to you in the time that we have. It's going to be difficult to hit them all there, but cocaine-related disorders have their own category, also being aware of intoxication options. And the category for F15 that started adding bath salts. I mean, we've heard some horrific stories in the news over the last couple of years, but it took a few years for these codes to make it into the ICD-10. So the other stimulant-related disorders should come from F15, whether it's amphetamine, methamphetamines, and look at that, even caffeine. And then bath salts, abuse, and dependence. So whether it's hallucinogen-related disorders, now you start getting into requirements, as you'll see in the alcohol area and a couple other areas, that instead of just saying in remission, we may need to get more specific when reporting it to describe early remission versus what we hope to see as a sustained diagnosis code for sustained remission. In this particular case, I'm pointing out that tip related to hallucinogens. Nicotine dependence, of course, please be careful to notice there are different codes for cigarettes versus tobacco versus dip versus other delivery options. And by the way, the 2021 ICD-10 adds vape-related disorders as its own section in the ICD-10. And in this particular case, whether it's cigarettes, chewing tobacco, or an electronic cigarette, just wanted you to be aware that the level of detail we provide here is just something that public health really benefits from by understanding and being able to track public health issues, social determinants of care and so forth. So be aware there. So just giving you these lists on 32 inhalant-related disorders. There are options for associated intoxications and psychotic disorders, mood disorders, hallucinations, and or anxiety. In the last section here, polysubstance, multiple substance or indiscriminate drug use as a catch-all category for many other items. So actually, I wrote this slide yesterday thinking that they would be kind to post the document at this point here. But actually, Philip and the team went ahead and sent them out to you. But I do ask you to notice in that document, and I'm gonna have to exit out of here, in that document that the blue items, bear with me here, the blue items in this document will link you to an external website from a company that is just, they provide data there. But look at the highlighted words. This is the level of detail that goes beyond what we just covered in the slide to confirm if it's opioid abuse, that I can't use F11.18. Because it does go to a 6th digit, I have to indicate whether there's opioid-induced sexual dysfunction and or sleep disorders and or other opioid-induced disorder. And so you can flip to any of these. Let's see, did I do any other highlighting there? I wanted to find a couple that had the withdrawal in there. Look at this. Here we have just regular remission, whereas let's see if we can find one that says sustained remission. All right, I didn't do a good search there. So what happens is when you click on this, one of these diagnosis codes, it's going to take you to a page that gives you the traditional impressions related to reimbursement. It'll give you, for those of you that deal with inpatient care, what diagnosis-related group was there, and it'll help show you a variety of different approaches that you might find beneficial in terms of developing your superbill or encounter form to include the level of detail needed when reporting diagnosis code. So last reference here is to go look at Miss Sherry Poe Bernard's book. Whoops, Miss Bernard's book there. I'm not selling her book, folks. I'm letting you know what I believe is the best resource besides the ICD-10 for diagnosis coding. And she knocked it out of the park with some great examples showing non-specific documentation and then alternative or better approaches to diagnosis coding to establish that consistency that we've discussed. So, got about 25 minutes to move here. Let's show you some of those other codes. Confirmation again about the need to educate on those official guidelines. Confirmation of what we said earlier, that the medication-assisted treatment, not the screening necessarily, will be dominated by evaluation and management codes. And the one thing I need you to do is take slide 36 and mark out and draw a line through this bullet. I did not, and I apologize, I did not notice until this morning that I had that in there as a remnant from 2020. So that one's on me. And based on our hour and a half last week, we're more aware now that we code based on time or medical decision making, whichever gets us to the higher code. And then the opportunity. Okay, I saw some chat up there. I couldn't see. And then, we'll show you some of these options there for the for screening services. So here is a slide that you see already has a bunch of arrows on it, and it was actually intentional by me to show you some confusion here, because if you're not really in depth and aware of the differences between proper coding and how billing actually may change based on the patient's insurance, you might have a code there, 90791 or 90792, that you're going to use for psychiatric evaluations to regular old insurance companies. But if it's Medicare, they require us to report that magic G code followed by that by that 90791 based on what we'll look at in a moment, which is the FQHC qualifying visit list. We might have traditional psychiatric therapy services, 25 minutes of insight-oriented or behavior-modifying therapy. I use the 90832 or 834 coder codes, but then for Medicare, I have to add the G code. So please give your billers a hug and a good budget and a high five and a raise and a training budget, because they have a very complicated job to translate sometimes the CPT codes into what Medicare wants, because we get paid with that encounter rate primarily rather than our fee-for-service rate. So the psychiatric collaborative care model, that's what you use for commercial, but GO512 for Medicare and maybe Medicaid, same idea. Online digital E&M codes are in the CPT, and the CPT tells you can report online digital E&M codes. But did you know, as an example, that there are codes G2061 through G2063 for online assessment by your PA and by your NP that captures up to 7 days of total time done there. So this is really just designed to confirm the difference, as we talked last week, between our online digital E&M visits and virtual services, and the differences in coding and billing that you'll see there on the bottom of slide 37. Continuing, please, on slide 38. Okay, I actually do see some of the chat things pop up there, folks, but they disappear in about 1.5 seconds, and I'm not able to read them there. All right, so it is going to be necessary for those of you that report medication-assisted treatment services to Medicaid carriers within your state to grab your HCPCS manual at some point following this call, if you have not already, because I can't list them all here, but you're going to go need to review the full definition of each of these H codes. That happens to be the only, I believe, the only chapter in the HCPCS Level 2 code book that is written specifically for Medicaid. So let's say you have alcohol and or drug assessments that are maybe have a CPT code 99408. Or maybe there's other options, and you submit that, and you get paid by all your commercial insurance companies, but you bill them to Medicaid, they deny you, and you pick up the phone and say, hey, how come we didn't get paid here? I thought I used the correct code. Is there another code that we're supposed to use to get paid by you, Mr. or Mrs. Medicaid? And what do they say? I'm sorry, I'm not allowed to give you billing advice. And so that's what I'd like you to take slide 38 as. That there may be specific codes for crisis interventions. Heck, look at this one. For those of you that are doing high intensity outpatient care for patients where it's not a, once a week, give or take, visit, but you have alcohol or drug intensive outpatient treatment lasting 3 hours a day with 3 sessions per week, that there's one code that your Medicaid carrier might want, H0015, that includes both the assessment, the crisis evaluation, the activity therapy. Heck, it could even include provision of the medications. H0032, if your non-physician, so your PA, NP, clinical psychologist, or authorized clinical social worker is doing mental health service plan development, not a CPT code, but an H code. If the patient's receiving the oral medication from you, H0033 or 34 would help reimburse these services. So if you don't know these codes exist, they're not allowed to give them to you. Maybe they're in your Medicaid manual. I hope this can help generate revenue, whether it's handling non-blood specimens or screening or brief intervention or drug testing collection, to perform those qualitative or quantitative testing, and or some codes that are, I like these codes better because they're more per diem codes or per day codes that cover the medication, the treatment, the community services, and everything out there. Now, again, there's 20 more codes that I didn't fit on this screen. Please go review those when you get the chance. So quick highlight, everybody on this call, unless you are brand new to an FQHC, are aware that the first code that goes on a Medicare claim for you to get your PPS rate is going to be either G0466 or G0467, followed by the code that authorized you to report this service. So the code or codes that are there for G0468 would be the HCPCS codes for the IPPE, G0402, or the annual wellness visits. What is it? G0438, G0439. And if I don't have, following G0468, one of those 3 codes, I don't get my PPS rate. But mental health visits have their own codes. I kind of wish they'd put medical in the definition of the first 2, as they did put mental health here at the bottom. All right. But, please do recall, as we're doing this and just kind of giving you the overarching general issues there, that you need to make sure you have the list of services that you would use to report G0469 to get your PPS rate, because it needs to be one of these 7 codes: the psychiatric diagnostic evaluative interviews, the therapy, a psychiatric service performed during a crisis state, or psychoanalysis. So you'll notice the code for G0470 are very similar, if not the exact same, actually, I should say, for new and established patients. But on the medical side, if you're performing an annual alcohol screening or brief alcohol screening, etc., notice that is designated as a medical service to report the master G code for new medical visits. Look at the codes that Medicare authorizes underneath its qualifying visit list. But you should have one of these codes for G0442 through G0447. But notice those are not mental health. Those are considered medical visits. And in particular, G0442, G0443, dealing with substance use disorders. And, those may be the primary services you're reporting there. We talked about this for an hour and a half last week. We talked about the changes. You can get paid via telehealth for group therapy and things you never could during the public health emergency. We showed you the spreadsheet and went through it, so I'm going to continue to move on. I did mention methadone, Suboxone, buprenorphine, and naltrexone are the 3 primary medications used, and I mentioned earlier that methadone is dispensed via a certified opioid treatment program, which is likely not your FQHC. Here it is, again, where we talked about the potential need in order to provide buprenorphine, okay? You have to get that data waiver to get an XDEA, Drug Enforcement Administration license, and that the provider's training had been 8 hours, PAs or MPs, 24 hours, and I wanted to give you a couple places you could get that training. Clinical Support System or the Addiction Society of Addiction Medicine. As of now, it is assumed that you, if you are authorized in your state and have a traditional DEA license, you are likely already authorized to prescribe naltrexone in order to get your program up and running if that's what you're using. There should not be significant administrative barriers as there is right now for buprenorphine, okay? So we mentioned earlier, expect a tremendous variation in reimbursement there. And I wanted to also give you another type of waiver that might allow you to transform your substance use disorder training. But I'll tell you, I went this morning to verify the hyperlinks, and that darn link didn't work. So I'd like to apologize in advance there. So here's the issue that you see on slide 45 that I had written in this slide on January 14th was going to give you even more positive news related to the ability for providers to maybe not have to undergo additional training to get that Data 2000 waiver. Well, folks, no joke. This came out last week. What is it? Last week? Week and a half ago? And what this document did, and again, it's a hyperlink, all right? What this document did is removed a restriction that required providers to get that for physicians now, not anybody else, but physicians to have to get that waiver. And I thought this was a wonderful, wonderful development. January 14th, eliminating the X-waiver requirement for DEA-registered physicians to prescribe buprenorphine for opioid use treatment. Now, watch what I'm about to have to ask you to add to your slide. If you printed your slides out and you're making notes, here's what you need to add. Newsflash, Washington Post article, I think it's from today, states that this may not go through, that the administrative process that was utilized to issue this relaxation of rules didn't follow traditional, or may not have followed traditional HHS rules that require them to notify Congress, et cetera, et cetera. I think that what I would hope is that the general area, now this was yesterday, I wrote in here areas that I believed remain to be fixed. Now that's before the Washington Post article, but it remains an issue. There are some surveyors in some states that when you provide medication-assisted treatment, they're deeming you a specialist, which could violate a traditional requirement in rural and health professional shortage areas that you have to provide over 50% primary care. I've been at local and state and national conferences, and I've heard people saying we have a great medication-assisted treatment program, but because we're providing behavioral health, those providers were deemed specialists and that they were told to stop or eliminate those services so that they wouldn't be in violation of the primary care dominant requirement. That still needs a fix. PAs and MPs are still likely going to have to do it, but here's my news flash on 46. I do not have the link here. I might have to ask Philip. I know you didn't expect this here, but there is an article. If you went to Google it, right here. I might be able to put that in the chat. I'll try to put this in the chat box. But if you Google Washington Post, what's the date on there? Okay, that was last night, 6/10. Indicating the Biden administration preparing to halt that plan, okay? But when you go down deeper in the article, it says that somebody that had to speak on condition of anonymity said that the agency would continue, make it a little bit bigger, would continue to pursue other options to reduce requirements on doctors before they can prescribe the drug. So in our last couple minutes together, I want to show you the overarching slides that confirm everything we've talked about, from options that you might use for common screening tools, whether it's the SBIRT tool, Assist, KJ, or whatever. There are a lot of opportunities you have to determine the clinical screening tool that you use for medication-assisted treatment. You don't need me to list and read these codes to you, but here are some possible coding options for screening services from alcohol or substance use that includes a brief intervention. These are time-based codes. Annual alcohol screening, brief face-to-face visit for alcohol misuse, and some possible G codes that you may need depending upon the care you're reporting. We've talked already about the need for screening assessments and interventions, that the initial assessment can be performed specifically for substance use or done during a regular medical visit or a regular mental health visit. I encourage you to utilize slide 50 along with some other options for substance use, not just that use, and the H codes that we mentioned a while back. Induction and follow-up visits, expect variations, but as I pointed out earlier, these are going to be mainly by your medical provider, possibly using H codes, but the E&M guidelines we reviewed last week are important, and all of these items are also found in NAC's wonderful guidelines back there in Appendix D, E, and F. In order to kind of finish up here and remain on time, there are some codes that those who have methadone clinics or opioid treatment programs are using, giving you some research links. I hope these come down the line so that instead of having a bunch of different options, we just have something that says medication-assisted treatment for naloxone weekly that includes everything we've done. But please be very careful to note I'm indicating those may be in the future, and this is only for those that have approved programs, not FQHCs, but I wanted you to see that was there. The next couple slides go into the requirements for each of those services that were listed on the qualifying visit list. So you need to know what documentation is required for those psychiatric diagnostic evaluative interviews. Please read your CPTs. And slide 55, what documentation is needed for therapy that's being done in parallel with medication-assisted treatment, giving you slides 56 and 57. And whether it's psych or neuropsych testing, folks, the last section here is for transitional care management and the behavioral health integration. And I apologize, I didn't have the time to do it based on what else we were talking about. But I do have a lot of good information in here on behavioral health integration, several different hyperlinks to specific information designed for FQHCs. I hope this training has been beneficial because it applies to what you deal with on a day-to-day basis. And then an outline of the psychiatric collaborative care model where your medical provider and your behavioral care manager might utilize the services of a psychiatric consultant who maybe is living in a state next door. And so what I've done is taken the model of the psychiatric collaborative care model to include job descriptions, FTE requirements, and recommendations for the vital roles of the care manager and the psychiatric consultant there. And so I apologize for having to sneak this in at the very ending, but if you're interested in finding out information for that behavioral health care manager, information from that University of Washington format there. If you need information on the role of the psychiatric consultant that may never set foot in your office, but they may be there because they have awareness of, they're a psychiatrist and they can help manage the psychiatric medications that are being provided in parallel with potential medication-assisted treatment. So in that particular case, I have the coding from the CPT there, along with billing Medicare for the psychiatric collaborative care model for about $145 payment. I've got to open it up here now for Q&A. Philip, I apologize for going a couple minutes over there. And for those of you that may have questions based on those slides I had to hurry through, My name is Gary Lucas. I serve as Vice President of Education for Arch Pro Coding. You can reach me at Gary at Arch Pro Coding. And I think Philip has a link to send to you also for a 2-day boot camp we're providing February 2nd and 3rd that can allow you to become a community health coding and billing specialist. But Philip, I'm going to let you jump in here so I don't go too far over time. I thank you all for your significant work that you do. And if you've been trying to wait on a sign for whether or not you can report medication-assisted treatment, if you've been waiting for a sign, folks, this is it. We hope this expansion of services in community health continues, and we hope that we've provided you some guidance to help you get paid for it. Thank you very much.
Awesome. Thanks again, Gary Lucas with Arch Pro Coding. Want to just give one minute to someone who is asking some questions. So Lorraine, I'm going to unmute your mic so that way you can ask your question for Gary.
Perfect. I see a question. Our LCSW does the initial interview to see if a patient qualifies for the program, then sets them up for their first visit with a MAP provider. Big question is, can the LCSW bill for this service, or is it all inclusive with the first visit? Well, it depends on what was done, but, two things there. If it's Medicare, we got to make sure that the licensed or limited clinical social worker meets the definition of Medicare's guidelines for what a clinical social worker is. And the way you've got to do that is by going FQHC, CMS, Chapter 13. And when you get the chance, look in the Medicare Benefit Policy Manual, or please reach out to me afterwards, Lorraine, if you're not there. But you should be able to go through here and determine, for example, what the requirement is for that clinical social worker in terms of a master's degree or a doctoral degree, that they've had 2 years of supervised social work, etc. So that would be one element there. What else was performed? If you're billing Medicare, you got to meet that qualifying visit list. But please, Lorraine, I need to let you jump in if you can.
Yeah, so look, okay, so, all right.
There's a lot built into her good question that
yeah,
probably would be better if she and I got on the phone, or just I exchanged an email, please.
Yeah, and it looks like her audio, it might not be connected. So we'll just get one last question in while we have you, Gary, and then we'll let everyone go who's still staying on the line with us. So it says, do you know which telehealth modules are approved for Medicare to approve group therapy?
Yes. The same link we sent out last week, but I realize everybody may not have been on that call last week. I need to share my screen.
Yeah, I was just about to say, if you're showing anything, you can jump it back.
So yes, if I'm understanding, can you read the question again just to make sure I'm answering the questions, the question that was asked?
Yep.
All right, am I aware of which modules, or what can be billed via telehealth? Is that the gist?
Yeah, it says, do you know which telehealth modules are approved for Medicare to approve group therapy?
So if I'm understanding it, this list is the one that was been most updated in January of 2021. And if you literally just Google CMS approved telehealth list, it'll take you to CMS, and you'll get the same list here. And what it shows a short descriptor, the status of that code. Can you do it via audio only? And are there any payment limitations? So for example, right there, 90853, group psychotherapy, is on the telehealth for distant site telehealth. Even if it's done audio only, it's allowable to bill for Medicare. And any service on this list that you perform, not just the ones I'm highlighting here, is allowed to be reported during the public health emergency, or notice this, up through the year in which the public health emergency ends. So I expect this list to get updated over time. But for example, even medical nutrition therapy group during the public health emergency meets that list for FQHCs, and even that 99211. So the quickest and fastest way to do it is to just search that list. And by doing it this fast, I can even misspell telehealth, and it's still going to pull it up. And you're going to find that list. And I need to go back to this little link right here, and that's how you're going to find it. List of telehealth services. Boom, you open it up, it's going to pull that same list up that I just found. If that's what I understand by modules, Philip.
Awesome. Thank you so much, Gary. Really appreciate the extra time. Really appreciate the 200 plus folks that have stayed on the call getting this information. As always, I went ahead and took a copy of your questions, and I will send them over to Gary. But if you do have a specific question for Gary, you can see his email is down there in the orange, gary@archprocoding.com. Feel free to send him an email. If you don't get that email, feel free to send it to me, and I'll pass it right over to him.
Yep.
Just as a last reminder, we will be sending out the recording to part 2 in about just a week. So you'll receive an email from me with your CEU certificate and another copy of today's slides in addition to the document that Gary referenced, and you should be all set. So if anything else, feel free to email me with any of your questions, and I'll get them taken care of. But once again, thank you, Gary, for this 2-part series. We definitely appreciate it.
Yes, sir.
Definitely keep posted to look for more from Gary and Arch Pro Coding in the future. So everyone, take care. Enjoy the rest of your week, and we'll see you at another event.
Thank you, Nat. And thank you, Philip and Brandon and Olivia. Thanks.
Thank you.
Thank you.